Welcome to CG Podcast. We're here today to discuss The COVID Consensus, a book launched on January the 23rd, 2023, 3 years on from the first COVID lockdown in Wuhan, China. And I'm here with one of the authors, Professor Toby Green, a historian specialising in African history at King's College London. He wrote this book with Thomas Fazi, who is a writer and a journalist. Welcome, Toby.
Thank you, Lucy.
I'd like to know, first of all, what brought you to this topic as a historian of Africa?
Well, it's quite a long answer, in fact, really. But, you know, when the lockdown policies began to be rolled out worldwide in March 2020, I'd been spending the previous decade, 15 years, working intensively with colleagues across the African continent on a variety of different projects. And so I was regularly in communication with people in different countries, and very quickly I built up a picture of the way in which the policy which had begun in China and then moved into Italy and then was being rolled out across Europe and the Western world. And then March the 23rd, Britain went into lockdown. March the 24th, India went into lockdown. And that week, a number of different African countries went into lockdown. And I was talking to friends, and one of my oldest friends in West Africa, in Senegal, Mamadou Ndiaye, who I've known for almost 30 years, was telling me, you know, he had been, in the middle class. He was, he had a good business. He had his own. He was using his motorbike to go to the sea, buy fish, bring it, sell it in local markets. There's plenty of money circulating in the local markets in Senegal where he lives, and suddenly that was all gone. And because of the nature of the lockdown policy, particularly in poor countries, if you start a policy which has to be enforced by the state, and the state is weak, it will generally be enforced with quite a lot of brutality. So people were beaten if they went out into the streets. And very quickly it became clear that this is an impossible policy, for poor countries. And yet it was being rolled out with this enormous vigour around the world. And so straight away, really by the end of March, I was extremely concerned about what this meant.
So, but why do you think that developing countries went along with it, given the obvious concerns about malnutrition and food poverty?
It's an extremely good question. I think you have to look at the way in which global governance has developed in the last 20 or 30 years, and the way in which there's a sense of good governance being an important part of, being a well-governed country is the way in which you get loans, is the way in which you get development resources and infrastructure. Being bad governance means you don't get those funds. So there are lots of reasons why, and I suppose I often say to people, here's a counterfactual. Can we imagine a situation in which the whole world followed this policy and the African continent said, oh, well, sorry, we decided that's not appropriate for us. We're going to go away. I mean, that's just not realistic in terms of global politics.
So you feel it was the influence of the West and the World Health Organization, perhaps, that put pressure on developing countries to impose lockdowns without considering the collateral effects on people who had.
I mean, it absolutely was, and I've interviewed a number of colleagues in Africa who say this. That the World Health Organization and their African affiliates put pressure on, and of course we have to also bear in mind that this is a context where the WHO funding is responsible for a lot of basic primary healthcare programs in a lot of different African countries. So refusing to follow their policies on COVID would have a lot of knock-on effects.
But it then begs the question, why did the WHO, which is obviously a multinational organisation, go along with it too? Why did it
I'm afraid the WHO didn't just go along with it, it imposed it. In its report after the visit to Wuhan, the WHO team which went to Wuhan at the end of February 2020 recommended in its February 25th, 2020 report the use of lockdowns in all countries where the cases were found, regardless of socio-economic conditions. And this is extraordinary because, in fact, lockdowns had been trialled during the Ebola outbreak in West Africa in 2014. They were trialled in Monrovia, and they were trialled in Freetown. In Monrovia, in Liberia, there were riots. In Freetown, Médecins Sans Frontières warned against imposing them and then said afterwards that there'd been a failure. there was clear evidence that this was not an appropriate policy. So
or even with something with a high infection to fatality rate, like Ebola, it didn't work.
No, and it created a lack of trust in the medical authorities.
But did it not reduce infection rates?
No, because the thing was that it created the reason why the Médecins Sans Frontières warned against it was firstly because of the fact that, as one of my Nigerian friends says, this is a policy which can work in our context for 3 days. Okay, it can't work for longer than that because people will starve. And so it can't work in that context for the reasons of the socioeconomic framework and fabric of African society. So, and also it creates a huge lack of trust in the health messaging, and that's another important fact. Because given that, if you impose this policy, of course it's going to create a lack of trust in people who can't follow these policies in order to survive.
I want to sort of pick out, I know it's difficult to do because we've got the whole globe and developing world, but just some of the things in your book. I mean, I picked up, 1 in 7 of the population reside in slums, they can't lock down. You have some really startling figures about the amount of poverty, children under 5 that develop malnutrition. Can you think of some anecdotes?
2 or 3 things,
just some illustrations about what lockdown meant for people in different countries. I know you've got a section on India, so if we can just go around.
Well, let's pick out 3 things. Yeah. Okay, so firstly, yes, as you say, statistically, 1 in 7 people around the world live in slums. So let's think about the realities of lockdowns in slums. So what happens in low-income countries where temperatures are generally warm is that people spend as much time as possible outside. Why would you spend your time inside where your living conditions are poor? You spend your time outside. So curfews, lockdowns, crowd people together inside. So they're not only impossible for people to continue socioeconomically, they're actually counterproductive in terms of circulation of the virus. I mean, it's the most extraordinary policy, and it shows an incredible, it's actually contrary to any kind of scientific understanding of the virus spread to do that. So that's
isn't the idea, though, that if we stay inside and don't mix, then we would slow the spread and help prevent it hitting more vulnerable people and slow the potential impact or mitigate the potential impact on health systems.
Yeah,
and that's been one of the main arguments, and we didn't want to see health systems overwhelmed.
Yeah, I think that was the main argument, and it makes sense if you live in Geneva, where the WHO is based, but it doesn't make sense if you live in Nairobi or Accra. I mean, in terms of slowing the spread, you're not going to slow the spread, you're actually going to concentrate people together and increase the spread. That's the whole point. And so, for example, a very interesting example would be a very old friend of mine who lives in Chile, in the capital city, Santiago. Her mother told me in their neighbourhood, which is quite a poor neighbourhood, that many people's work stopped, and what it meant was that people developed kind of soup kitchens, communal kitchens, and they all came together to access the food. So the man who ran the one near to where she lives, because they all came together, in fact developed COVID, and 3 people in his household died. So instead of taking account of the different socioeconomic realities and the ways in which people live and how that affects virus spread and how those aren't all the same and they don't all follow the basis of what happens to people who live in Geneva, we implemented a policy which, so in the case of slums, it's completely counterproductive, in fact. So the second example I would give would be, let's think about education and 2 examples, Angola and the Philippines. So in the Philippines, children were not allowed to leave the house between the ages of, I think, 5 and 15.
For how long?
20 months.
20 months not allowed
20 months not allowed to leave the house. Now, of course, people say, well, not everybody would have observed that. But the president of the Philippines, Rodrigo Duterte, is known to be a very authoritarian leader. Now, I'm sure a number of people did observe that. And not only that, when children did start to go out, the families who were taking them out were, in fact, often bein criticised and abused by people in the street. I mean,
well, I do remember seeing images. I have friends who live in the Philippines.
Yeah.
They would parade children who'd been broken the rules along the streets, and they would have to walk hand in hand and be humiliated, really.
So yes. I mean, that's quite extraordinary. Angola, I interviewed a colleague in Angola, and in Angola it wasn't 20 months, but for 7 months children weren't allowed out of the house in Angola. Again, an authoritarian country.
So as a historian, never had we seen anything. People do talk about in medieval Britain, in the plague, during the Spanish flu, we had quarantines and we had lockdowns. Were they comparable?
No, and I think one of the very important differences is that in those times, when of course there were quarantines, they were localised. So a good example would be Angola. So the colleague I interviewed in Angola said, that when the lockdowns were initially implemented and rolled out at the beginning of April 2020 in Angola, in rural areas, there wasn't a single COVID case. They weren't allowed to leave their homes. They lost their harvests, created massive food poverty. People lost their food security. Many of them had to migrate to cities. So so the first point is lack of localization of policies and of quarantines. And I think it happened in Spain as well, actually. In the original lockdown, there were hardly any cases, I think, in the Balearic Islands, and yet they were put into a lockdown. So that's one of the key differences. And then another important difference, which we'll come on to, I think, is the relationship between lockdowns and vaccines. And that's a very different dimension of the quarantine policies.
Move on to that.
The third example I was going to give was this question you raised of malnutrition. So we knew the WHO actually published a malnutrition fact sheet on the 1st of April 2020, just as these policies were being rolled out, which reiterated that 45% of infant mortality under the age of 5 is due to malnutrition. And we knew that these were policies which were going to increase malnutrition. So clearly this has had
And in your book, I think you've said there was a UNICEF report with 100 million extra children in poverty as a result of lockdowns and 230 million pushed into poverty. So worldwide, So we definitely, I think there's another fact, 900,000 lives lost under 5 during 2020, I think something like that. But definitely there's some big figures about...
we just know that, malnutrition, poverty creates malnutrition, malnutrition creates infant death. Those are just statements of fact.
And, it's very hard to say, well, we would have also saved lives by slowing a spread. We can't really ever know how much lockdowns contributed to... In those countries, slowing the spread of a disease whose health systems were particularly unable to cope.
There's various issues. Firstly, as I say, it's perhaps partly horses for courses. It's not going to be the same in those contexts because of the different socioeconomic conditions. But secondly, we've got to also bear in mind that the median age in Africa, according to the UN, in 2019 was 19.8. Now, it's well known that this is a disease which greatly affects older people with comorbidities. So the idea that this was a sensible policy in that context beggars belief, frankly.